about the post-operative complications of trabeculectomy and how to manage them. Dr. Surajit is the Chief Glaucoma Consultant at Priyambada Birla Arvind Eye Hospital. He has been trained in glaucoma at Arvind Eye Hospital, Coimbatore, and has been the East Zone Glaucoma India Program Coordinator of GSI. Thank you, Dr. Surajit.
Thank you, Manish. Thank you. Hi, audible, I hope?
Yeah, you're audible.
Okay, thank you. It's actually a huge topic. For a short time, I think I will get some extension. So here I go. We all know that glaucoma is known for complications, glaucoma surgery, and there are some dreaded complications which we are scared to look at, like these. But not all the patients will have this kind of problem. So let's start the usual complications we face one by one. So commonest is a shallow anterior chamber that can be associated with high IOP or low IOP. The high IOP conditions are pupillary block, malignant glaucoma, posterior pushing mechanism, posterior scleritis. The ones with low IOP are more common with wound leak, bleb leak, overfiltration, and sometimes cyclodialysis cleft. So coming to the leaking bleb. Early leak can be treated with aqueous suppressions, withholding or reduction of topical steroids, topical aminoglycosides, pressure patch, large diameter DCL, fine articulate glue application, corrective surgery, and old leak has to be, there has to be a bleb revision. This is a photo of pressure patch by torpedo bandage. Torpedo, the name comes from the shape of this pellet, which is put over the upper eyelid to create a localized pressure to prevent overfiltration or leak. Or other way to treat is with tissue adhesive. With small leak around the limbus, it can be working very well with tissue adhesive. As you can see, after 7 days, the tissue adhesive has fallen off and the blade has raised. Late leaking blade is always inevitably go for a surgery, and we have to excise the whole part of the leaking blade with excision of the fibrous tissue and cover it with a new scleral patch and close it nicely. Next complication comes the choroidal effusion. We have to be very careful to discontinue any medicine which can cause a choroidal effusion, and wait a while. Cycloplegia may help. Modulation of topical steroids and systemic steroids. Reformation of anterior chamber with viscoelastic air or gas may be required, and sometimes draining or reformation of anterior chamber is required. And if there is a leak, then resuturing of flap along with the graft may be required. A cyclodialysis cleft is another entity. It can be viewed with gonioscopy, but it is very difficult because in a hypotenuse eye, it is difficult to do the gonioscopy itself. Better visualization is with UBM and cycloplasia, laser diathermy, cryotherapy, surgical closure may be required. You can expect a high IOP after closure of cyclodialysis cleft. In the early postoperative period, a low IOP and elevated bleb. Think of overfiltration. The overfiltration can be treated with a pressure patch, large diameter contact lens, compression cell, injection of autologous serum or blood in the bleb, reformation of anterior chamber, and to drain the choroidal sometimes and resuture the flaps. The simleferon ring, rarely used these days, may be of help. This is a photograph of autologous blood injection. This is a bleb compression suture. And if in early postoperative period there is low IOP with shallow anterior chamber, aggressive treatment will be required if there is a lenticulocorneal touch or corneal decompensation and chance of bleb failure. Also, aggressive treatment will be required if the choroidals are very high, that is nearly a kissing or a kissing choroidals, and there is a need for rapid visual rehabilitation. Well, when there is high intraocular pressure with flat blade and shallow anterior chamber, think of these three entities: the suprachoroidal hemorrhage, aqueous misdirection, and pupillary block. And these are the risk factors, predisposing factors for suprachoroidal hemorrhage. In these conditions, you have to be very careful while treating. And there is sudden onset of pain intraoperatively. If it happens, you need to close the eye, close the incision immediately. And if it happens in postoperative period, for example, after suture removal, supportive therapy, analgesia, aqueous suppressions, cycloplegia is administered, and drain when the ultrasound evidence of liquefaction, because if there is active bleeding, it may recur again, and that can cause dangerous suprachoroidal hemorrhage. The other entity, aqueous misdirection, there may be a prior angle closure. Iridotomies are not curative in these cases. Rather, iridotomy is a criteria to qualify it as an aqueous misdirection. Medical therapy, laser therapy, and surgical therapy are administered. Medical therapy consists of atropine, aqueous suppressants, hyperosmotics, steroids, phenylephrine, and laser therapy may be with YAG hyaloidotomy, that is rupturing the anterior hyaloid face with a YAG laser to create a space between the posterior segment and anterior segment, and shrink the ciliary processes with argon laser may be of some help to break the addition with the ciliary processes. Surgical therapy can be required to lyse the hyaloid, and pars plana vitrectomy or pars plana vitrectomy with trabeculectomy or drainage tube may be required very rarely. Pupillary block is relatively easier to treat. A simple iridotomy resolves the problem often, and control of inflammation is required to maintain it. Next, coming to the warning signs, the failing blade. When the IOP is high with a formed anterior chamber. The failing blade shows a flat disposition, vascularized, and no microcysts. It is usually preceded by a gradual increase in intraocular pressure and change in the blade's appearance. The surgical factors which causes a failing blade may be tight sutures, or blocked stoma, or a retained viscoelastic. But most often, this is the most notorious thing. The episcleral scarring is something which causes blade failure. There may be three potential sites for your outflow resistance: the internal sclerostomy, external sclerostomy, episcleral subtenon's capsule. Gonioscopy has to be done before you go for a surgical intervention. Sometimes the pilocarpine is of some help, especially if it is a very fresh blockage with iris tissue. It drags the pupil away from the wound, and argon laser or ND-YAG laser may be required to open up the stoma from internal aspect. So the normal algorithm is like this. If you get a failing blade with the stoma still patent, increase the steroid to reduce the fibrosis, and subconjunctival 5-fluorouracil injections may be of help, and digital massage and suturolysis or releasing of the sutures are of utmost importance. Blade massage, it is essential to establish the subtenon's aqueous lake at early postoperative period. Let us have a small video, but I think we'll skip it because of interest of time. Suture release is very important. Please remember, it is mostly done between 2 to 6 weeks. More time can be allowed if you are using antimetabolites, and antimetabolites really lengthens the time. Very early release can cause hypotony, and very late release will cause ultimately a blade failure. So a timely suture release is of utmost importance. You first do a blade massage to see how the blade is elevating, then do a suture release. Prashant has shown you the putting up the releasable sutures, and this is how you release it. And after that, you definitely need to give a nice blade massage to elevate the blade. And this is argon laser suture lysis. I'm not going into much details. The other problematic feature in postoperative period is an encapsulated blade. Is more common in young patients. Topical beta blockers or aqueous suppressants are of some help. Most start functioning in a few months. If not, then blade needling has to be done. This is how you do a blade needling. You choose a place at least 10 millimeters away from the site and enter with a 26 or a 30 gauge needle and to and fro side to side movements while passing through the sclerosed fibrous tissues, and you can reach up to the anterior chamber. A sudden shallowing or softening of the globe will be noticed. Some small amount of bleeding also can go into the anterior chamber, and that's it. To break the adhesions to in the subconjunctival fibrosis area, this is of much help. Well, when a blade has already failed, what to do? The usual algorithm is to restart medicines, do a gonioscopy to see whether any stomal blockage is there, and if not, then you go for a needling, and blade revision can also be required. The final treatment is with retrieval or a shunt surgery, which Dr. Manish has depicted nicely. One of the most dreaded complications is blebitis and endophthalmitis, the infections. Please remember, bleb infection is an emergency because it has a direct communication with the internal structures of the eye. So patients should be told to seek ophthalmological attention immediately if they develop purulent conjunctivitis, because patient may think it is a conjunctivitis. Ultimately, it may be an endophthalmitis. So it has to be treated seriously and as soon as possible. Well, cataract progression is a very common complication of glaucoma filtration surgery, and you can avoid it by having a postoperative hypotony. If you have a postoperative hypotony, you run the chance of getting cataract more. So please try to avoid it. Avoid direct lens trauma, and please consider combined cataract and filtration surgery in primary glaucoma if there is a significant lens opacity. Last but not the least is the wipeout of remaining visual field. This is a very rare but very important complications of filtration surgery, particularly if the field of vision is constricted to less than 10 degrees of fixation. Prevention is to avoid and treat any pressure spikes. As much as possible, pressure spikes should be avoided. And also in the block, during giving the peribulbar block, adrenaline also better to be avoided. And precautions to avoid peri and postoperative hypotony. And perioperative systemic hypotension is another factor that can cause a wipeout. So to summarize, post-trabeculectomy shallow anterior chamber can be associated with both low and high intraocular pressure. We need to pinpoint the cause and treat accordingly, maintaining as much as possible the delicate balance between preserving the visual function and bleb function. In failing blebs, early recognition of problem and timely intervention is necessary to retrieve the bleb function. And please remember, bleb infection is an emergency. Patient post-glaucoma surgery should be told to seek ophthalmological attention immediately if they develop a purulent conjunctivitis. Thank you so much. Thank you for your patient hearing.